Hey everybody, welcome to the Med-Legal Greenroom. I am Sam Frentzas, co-founder of the Driving Force Company, and very happy to have Dr. Patrick Porter here, founder of New Jersey Brain and Spine. Now, pay attention here, everybody. Founding chair, Department of Neurosurgery, Hackensack Meridian School of Medicine from 2017 to the present, and chairman, Department of Neurosurgery, Hackensack University Medical Center, and Hackensack Meridian Health Northern Region 2011 to the present. Welcome, Dr. Roth.
Thanks for having me.
And I did a little research here, so I'm going to let everybody in on stuff that you have 4 books written, if I'm correct.
That's right.
So, guys, I already started, so I'm gonna name these 4 books now so they don't get lost. Flourishing, the ultimate career capital, managing back pain for dummies, and that one I like. I'm starting that one actually first. The Me in Medicine and the End of Back Pain. I recommend all of these reads for everyone. Welcome, Dr. Roth, and thank you for being on the podcast.
Thank you.
So let's dig on in. I like to say let's go for the steak and not worry about the sizzle, and dig in. So I have my first question here for you. So how good is MRI at definitely diagnosing the origin of back pain?
So, MRIs, everybody, I guess, thinks of it as a gold standard, and it is in many ways. It's particularly good at diagnosing leg or arm pain. You can see when a nerve root's being compressed, but a lot of times the diagnosis of back pain is more subtle. And so, in my experience, at least, the MRI will give you a definitive answer about where the back pain is coming from in 50% or even less of the cases.
Okay, so then what other tests do you use when an MRI is not, a definitive diagnosis?
I use two other tests, one of which, of course, is very applicable to you. But one test I use is something called SPECT scan, which is a really interesting technology, which you can either do after the MRI and layer onto the MRI. There's software that allows you to just lay the SPECT scan results right on top of the MRI, or you can combine it with a CAT scan, which is what I typically do. But unlike the MRI, which is an anatomical test and kind of shows you what you look like on the inside, that just allows you to infer where the back pain may be coming from. The SPECT scan actually lights up in areas of inflammation and is much more accurate in terms of what's causing pain. The second adjuvant test that I think is really helpful are these flexion extension films. To look at dynamic motion of the spine through flexion and extension. And I find that extremely helpful in many cases. If you see dynamic instability, that's a very, very strong predictor of being a pain generator. And of course, the product that you have is really nice because it not only does it automate it in terms of exact numbers, but it puts people through a very precise flexion and extension. So if you just leave it to your hospital or to an imaging center, you're kind of at the discretion of the tech that's there in terms of how much flexion and extension the patient goes through. And you'll oftentimes miss some evidence of dynamic instability. For example, I see a lot of patients just not flexing enough because they're afraid to, or the tech has told them, don't go too far. So I
Yeah.
find those two tests I find to be really helpful in conjunction with the MRI in deciphering that elusive pain generator.
I couldn't agree with you more on that. And we talk about it, and we have that out of the International Journal of Spine Surgery about a definitive diagnosis. But what do you do when you can't make a definitive diagnosis?
So, and by the way, our system is not good in that situation, our medical system. But I think I think pain is really interesting, and pain is an experience, and you have to understand that with any experience, the brain does a lot of editing in that experience, and so even our normal sensations like our sight and our hearing are edited by the brain, but an experience like pain is really edited like the brain. So there is always some combination of physical therapy and cognitive therapy that will help patients when you don't find the definitive diagnosis. But I think, I told you before that MRI gives you a diagnosis 50% of the time or less. When you throw these other tests in, it gets up to be quite a bit higher than 50%. But there's still a significant part of the population where we can't answer that very simple. We put a man on the moon in the 1960s, and here in 2026, we can't answer that simple question. Why does
Yes.
my back hurt? Or why does my neck hurt? And in those cases, I think some combination of physical therapy and cognitive therapy is really helpful. And I think to me, it's really helpful to think of pain as a three-tier phenomenon. These tests we're talking about is looking for the stimulus or the pain generator. And that's an important part of pain for sure. But what happens is when a patient is in pain, they also have some adaptations their body makes. Maybe they are spending too much time in bed. Maybe they have muscle spasm. Maybe they're, holding their spine in a certain way. That itself can be worked on as well as part of the pain. And finally, working on the brain as the third component of pain, how the brain, based on the brain's experience, anticipation, cultural phenomenon, the brain interprets pain in a very particular way, which can be altered through therapy. So even in cases where you can't find the pain generator, I think you can offer help to these patients.
And what advice, and I'm going to pick your brain here and use your expertise. So two questions that I want to dive into a little bit here. So how would you guide, and this is advice for a doctor that's seeing a patient that can't identify the pain generator. What is your advice to them? How do you guide them instead of what I call swagging, scientific wild ass guess? How do you guide them into helping that patient? What would you recommend?
Well, I think that, what happens to a lot of practitioners is once they can't find the pain generator, they really want to get the patient out of their office because, there's a phenomenon called chronic pain, which is there are millions of people in our country with it. And there is no home for these patients. They're like the proverbial hot potato. Everybody's trying to get them out of the office. So, um, my advice, I guess, for those people are to listen and to acknowledge their pain. One thing that's particularly disturbing to these patients is when you tell them it's in your head, for example, or you have fibromyalgia is another common sort of diagnosis that you can hand to the patient to get them out of your office. But I do think that listening, acknowledging their pain, and trying to find a system where people will give them the time they need. It's really important, but that's not what happens. One of the phenomena in our country that's so crazy is that the treatment that you get for your pain doesn't depend on what's wrong. It depends on whom you decide to see first in the system. So if you decide you're going to start with pain management, you're going to get an injection. You start with a surgeon, you're going to get surgery. You start with a physical therapist, you're going to get physical therapy. It should depend on what's wrong with you, right? The treatment you get, not where you start or who you're referred to, but that's not the case.
Yeah, you know what? That just, wow, what a light bulb. Because, I had a problem. I went to a chiropractor for my lumbar, and I got my chiropractic adjustments. And I went to the pain management and I got my injections. Didn't even put two and two together. And then guidance for the patient. So I know this is really difficult because I think you just said it eloquently there. You're going to get the treatment to who you're going to go see. What
Right.
do you recommend for that patient that, they can't find the pain generator, have done multiple x-rays, multiple MRIs, and still can't find it, but they're going to go to that doctor or that doctor. What do you recommend for the patient? Because you're going to listen to your doctor. That's just how it goes.
Yeah.
What do you recommend for them if they question it or, you know, through your experience?
Yeah. It's like the old expression, when you have a hammer, everything looks like a nail to you. And this
Yeah.
is so what ends up happening is you want to find someone who is going to try to overcome that bias of only offering what they do. Of course, there's an economic incentive to do what you do when you see the patient. And you need someone who can step outside of that a little bit. I'm not saying it's easy. One of the books that you mentioned, I wrote, Back Pain for Dummies. It's really very much modeled in a do-it-yourself way. And the idea I had was, how to look for the correct provider. But I got to tell you, for example, the cognitive therapy, insurance companies don't always pay for it. In fact, they often don't pay for it. And so it's fine to say, you'd benefit from some cognitive therapy. Good luck finding it in the United States today.
Wow.
So I think it's a problem. I think medicine's very broken in many ways, but I think what my advice for the patient is you have to be an active participant in your own care. You have to really apply your own judgment to the providers you see. Your patients are pretty good at understanding who they can trust and not trust. But, short of having a front row seat in the, injection suite or the operating room, it's really hard for patients to know what they're getting themselves into. So I don't have a solution yet. I think the solution would be I think AI actually will solve the solution, because AI will ultimately allow us to identify, given the patient's constellations of symptoms,
Yeah.
where the best starting point is. And then AI will point, I think, the patient to that best starting point, and then that will eliminate some of the biases that occur right now. And I also think that whoever sees the patient first, it's really important that they do a deep dive into the etiology of the pain, not brush the patient off because they think the patient's crazy. A deep dive is a really important thing to do if they haven't had it yet.
That I couldn't agree with you more. And I know we have a lot of followers, listeners, from chiropractors to spine surgeons to people to even attorneys out in New Jersey. So please, any questions or you want one of the top guys, I would seek out Dr. Roth as well. And here's what I'm going to do. So for the first 10 people that DM me below, hit the word Dr. Roth, and I'm going to send you pick any one of the four books. I'm going to personally get the four books and send it out to you as a thank you, Dr. Roth, for being on our podcast, getting some great information. So my way of giving back, DM me, Dr. Roth, and I will send you, pick one of your four books. The first 10 that reach out to me are going to get a copy of the book. So don't delay and don't be number 11. Thank you, Dr. Roth. This is valuable information. Anyone that's in New Jersey, and I know we have a lot of followers from attorneys to chiropractors to PTs. I think there's another way to open the door and really connect with somebody who's at the top of their field, in my opinion, and look for the New Jersey brain and spine. Dr. Roth, thank you for taking time out of your day and being on our podcast.
Thanks for having me, and best of luck to you.
Thank you.